Good morning, everybody. I'm Barend Haar. I've been around a few years. I know some of the people who are attending. My background was in assistive technology for probably the last 30, 35 years. And I set up BES about 30 years ago with a colleague, Greg Amos. And these days, most of my time now, I'm kind of retirement age. I spend a lot of time with international standards and the like, and trying to keep up to date, just as I hope people are doing by attending this seminar. Welcome to you all. And just because we don't have the chance to meet each other face to face, I haven't really got much idea about who else is in the room, the virtual room, and you probably don't either. So we're going to start off with 3 polls, just so we as the presenters get a bit more feel about who's attending and what your interests are. So we'll give you a minute or so there. If you scroll down on the screen that's in front of you, if you could fill in all the boxes that apply to you. Thank you. Okay, Sophie, can you show us the results of the poll? Are you able to share those with us at this point?
Yes, so I still have a few coming in.
Okay.
We have around 81% voted.
The others are all at the coffee machine.
Should I stop it and then say that will be?
Yeah, let's see where we've got to now.
Yeah.
It should give us a feel of who's attending.
Let's see here. There we are.
Right, so over half are occupational therapists, and we have some physios, some engineers, and I'm scrolling down there on the employers who's employing here. More are from the NHS directly, some are employed by local councils, some are working for the commercial sector. And the age ranges here is, we've got about half dealing with youngsters, and 70% are involved with adults as well or instead of. So that gives us a feel for what we're covering today. So thank you very much. I need to get back to my presentation. Right, the Move Europe presentation is concentrating more on the younger generation. The comments which I'll be making today hopefully will be across the board, but parts of the presentation will be concentrating on children. So what are we covering today? First of all, we have a title, Do No Harm, Know Your Power. And maybe that's intrigued some. Maybe others will know exactly what we're on about. But we will start off at looking why we're saying do no harm, and what can we do about that. We'll be considering aspects of good practice, which patient groups does this apply to, and what do we mean by know your power. So this all goes back to the Hippocratic Oath. And most of us have heard of the Hippocratic Oath. This is what physicians, doctors sign up to. And along that, it starts off with, along the lines of, I swear by Apollo, the physician, by Asclepius, Hygeia, and Panacea. Well, that's where hygiene comes from, and that's where Panacea comes from. But the important thing is the second part of this, which is I will prescribe regimens for the good of my patients according to my judgments and never do harm to anyone. And that's the bit where we hear the expression do no harm coming from. What I'll do is try and move my face a little bit out of the way so it's not blocking the picture so much. So today's talk is, can we take this premise that the physicians come up with to apply this premise across all health and allied health professions. Why should it just be doctors that do no harm? Shouldn't it be all of us who are involved with clients and patients? And we should apply this to clients of all ages. If you're a youngster, it is just as important that when somebody's looking after your health interests as when you are coming to my kind of age and a bit older. And behind this premise is prevention is better than cure. So what can we prevent rather than waiting to the stage where we have to cure what somebody else has done? So where harm has occurred, what can we do to stop it from getting worse? So often when we see patients, they are at the stage where they have a need to correct something that has happened earlier in their lives. We don't usually get the chance to be preventative when we don't know if somebody's going to get MS or have a stroke or whatever. But the important thing is to get in there as soon as possible after the occasion has occurred. And then once there is some harm, what can we do to reverse the harm? So are we in a position where we can actually make things better, or are we just stopping things from getting worse? So these are philosophical questions in a way, but they are behind a lot of what we do in our everyday practice. And let's look at later on, what are your powers to make a difference? Can you do anything different from what you've been doing? How can we go about that? So how can harm manifest itself? Well, it can occur directly. For example, we can end up with physical harm. We can do something where somebody ends up getting a pressure ulcer. They can end up with deformities happening. And particularly where people are at risk is at the developmental stage as small children. And I've known many years ago of a mother who had a child with spinal muscular atrophy, and she used to place the daughter in the corner of the sofa in the sitting room where she could watch what her mother was doing in the kitchen. But the corner of the sofa wasn't in a direct line, so her daughter ended up with a scoliosis of the spine from always watching her mother at the same angle. And she wasn't really aware of what was happening from early life, but was happening to her daughter for later in life. We also have the mental aspects of how we treat people. And for many people, disability is a learnt experience. It isn't something that's in the mind, particularly again, we start with young children. They don't think that they have a disability as such. They may appreciate that they can do things differently from others, but if they keep on being told they are disabled, they can't do things, eventually they will pick that up. So how we approach people makes a lot of difference to how they develop mentally. And also the behavioral side of things. If you're told you can't do something enough times, eventually you'll get to believe it. And as a result of that, you will end up altering your behavior and end up with a negative view of what you can do rather than a positive view. So how we handle people, our patients, not just physically, but verbally, can make a lot of difference. And also the equipment we provide them with, does it allow them to do the things that otherwise their disability may stop them from doing? And then there are indirect consequences as well. For socially, if you're disabled, you can't get around so much. We all, well, many of us will know of the program used to be on Radio 4, was Does He Take Sugar? The experience many people have had on a wheelchair with a carer helping push the chair or whatever, that the carer will be asked the question on the assumption that if somebody is in a wheelchair physically disabled, they can't use their minds. And I've also seen that over the years with many kids with cerebral palsy and so forth who've got poor communication abilities, but they're still very, very bright underneath, and they're being treated because they can't speak clearly as though they're idiots. And that really isn't a good way to handle people. And there's the educational side, and Charlotte, covering Move Europe's, or Move in the UK's activities, will tell us more about that. But if you've got a disability, we really don't want that to get in the way of your education. So what can we do to facilitate people in a normal schooling situation. And then there's the family side of things. What can we do to help somebody with a disability to integrate with the family? If there's a youngster with a disability amongst 2 or 3 other children, then it can cause disruption, obviously, because of the extra attention that the child in the wheelchair or whatever needs. So what can we do to make everybody feel included, whether the youngster in the wheelchair can help carry things around and other aspects like that. So there are lots of areas where harm can occur, and what can we do apart from providing a piece of equipment? What can we do to educate people around us? And we'll come to that a bit more in a moment. Well, where should this approach of do no harm apply? Well, it should really be across the whole process of interaction with any of our clients or patients. So we have the assessment stage, and there should be 2 aspects of the assessment, obviously. One is, what can we do to ameliorate the situation now, but bearing in mind how some disorders are progressive, what can we do to make sure that our provision now doesn't do harm, or does a minimum of harm in the broader sense as time goes on? And the same goes for the prescription. And then we've got the delivery. Again, when you're dealing with youngsters, they can change so quickly. What we want to prescribe is something that can be delivered within days, if not straight away, rather than have to wait 6 months for someone to deliver it by when the child's grown out of it or no longer fits it appropriately. And then, of course, there's your training as professionals, keeping up the CPD side of things. And those of you attending today obviously have an interest in keeping knowledge up to date and say, oh, that webinar may add to my knowledge and may add to my thinking. And likewise, even though I'm in my 70s, wherever I can, I attend webinars physically or these last few months virtually. That's why I get involved with international standards. I'm finding out where the thinking is up to date and what is changing. But also equally important is your client and carer training, because not much good handing somebody a piece of equipment and they don't use it appropriately. I was in a hotel a short while ago, and at a dinner table next to the table I was at, there was somebody brought Granny along to the meal, and she had a chair and she had a cushion in it. And for a moment, they took her out of the wheelchair and put her on a dining chair. I noticed that this formed cushion had been put in sideways. So that cushion wasn't really doing too much for her posture or probably for her tissue integrity. And chatting to the people at that table, I just let them know that the cushion wasn't the right way around to see if I could be helpful. They were very appreciative of it and said, oh yes, we just bought this from the local shop. But nobody had actually told them that there was a front and a back to it. So little things like that can make a difference between success and failure. And obviously, if equipment is provided, if it's got moving parts or parts that age, then maintenance is important. And then appropriate to timing of reviews, because individuals' needs will change, their equipment will change, and maybe there's new opportunities that come with new products around the place to improve things. And of course, budgets will get in the way of everything, but we'll talk about that a little bit more in a moment. So I'm going to present a potpourri of some examples to illustrate the points we're making. And as Sophie said at the beginning, we hope to run some more webinars later in the year. And in the follow-up survey, we're going to ask you which areas you'd like to have more detail in. So I'll be touching on 1 or 2 things, but each one of these bits from the potpourri could be or is the basis of more detailed webinars. So let's start off with early life. And looking at mobility from the early stage, I said I'd discuss some things to do with youngsters. And when I first got involved in assistive technology, I was involved in providing with a company that provided equipment for very small youngsters to get early mobility. And on the early mobility side, it is so important because it's part of the cognitive development. And as we all know, or anybody who's had small babies, there's a progression we go through. we go from crawling to walking, and we start from proximal in the center of the body with rolling around a bit, start using our extremities more and more. And that's where the crawling to walking comes in. And from there, we go on to the stage of being able to feed oneself. And along the line, one's starting to learn what there is around us. There are objects around us. And what are they for? Where are they? How they got there? When are they important, and so forth? So it's all part of the learning process. But you only can get to these objects if you've got the mobility to do it. And therefore, in the early days when you're learning this, and you only have a relatively few months in early life when the pathways are set down permanently. And another thing that for children is learning responsibility, and you only get that with mobility. So powered mobility, which was a very hot topic 20, 30 years ago, when people felt that children under the age of 5 couldn't operate powered mobility. I was very much involved with programs where people from 9 months could actually drive a powered wheelchair. And power is not just for transport. It is part of your movement, gives you your spatial awareness. And it's also how you get around the places, how you express yourself, how you develop your own self-image. So expressing yourself is very much a part of what a young child is. We all hear about the terrible twos, and that is where particularly is a stage of development where children are establishing themselves. And the other thing about expressing yourself is learning to be naughty. Sometimes children do it for fun, sometimes they do it to be a center of attention. But if you haven't got the mobility means to do it or the tools to do it, then sometimes you're losing out on this stage in early development. And this is the current development of the chair that I was involved in 30 years ago. Is called the Dragon these days. But the beauty of this is got a seat that the child can press a button and get down to the ground and play at the ground level like other children, and then can come up on the elevator system and meet people eye to eye. So it does a lot for their spatial awareness, because as they drive around the place, they can see what they can run into. Sometimes they do it to be naughty, and sometimes it's learning where things are. So moving on the physical development, the equipment side is very important. And just like I said, a potpourri of things to think about. For example, a joystick position on a chair. Quite often, a joystick is mounted along the side of the arm support because that's easy for the engineers to put it there. But quite often, people end up then leaning to the side to get to the joystick, and they develop a scoliosis as a result of that. So midline, particularly for youngsters, is a better position for a joystick and have a swing away mechanism so get in and out of the seat. Even the wheels position on a chair is important. And again, going back to this, the Dragon here, the point of this chair is that the wheels are under the center of movement for the individual. So as they rotate around the place with the driving wheel, they're rotating around their center of gravity, which is a much more natural sense of movement than when the powered wheels are somewhere behind you. And we've been involved with a company in France that's made the first manual wheelchair where the wheels are in the middle. It's called a wheelie. And that is so much easier to use, and leaves so much less space to get around. So the equipment that's provided can make a lot of difference to people's abilities of what they can do. So moving on from those aspects, we look at skeletal development, and 24-hour positioning is so important because we do probably spend 8-10 hours a day in a lying position, and it's quite easy to develop deformities. If, for example, you're lying on your back, gravity will if you've got contractors, you've got your knees in the air, gravity will want to pull your knees sideways, and a number of people, if they don't have the legs properly supported, will end up developing a scoliosis as a result of that. And we talk about elements in sitting. And just as from the potpourri, let's just look at the position of thoracic lateral supports. And I just took these pictures off Google Images, and there's two examples here of seating systems which have got thoracic lateral supports in them. And as you can see, they're quite rigid, all at both are both at the same height. And here's another example. And the girl doesn't look particularly comfortable there. She's in not a particularly comfortable 90-90-90 position, but those lateral supports in the picture there are not really an ideal position to keep the person comfortable and accessible to what they're trying to do. So where you put them is quite important, and whether they facilitate the person's activities is important. So the other thing to look at here, sorry, my images are getting in the way. I'm trying to move them out. Let's see if that works any better. If we look at the spinal cord, when we look at a rib, it's attached to a vertebra. And what we tend to do with a lateral support is use the ribs to push and keep the spine aligned. And, sorry, if you just follow a spine, even if you haven't got any scoliosis, you'll find that the rib is always at a lower position than the vertebrae it's trying to address. When you get a degree of scoliosis we have here, the situation gets even worse. So basically what we tended to use a lateral pad for is to straighten up the spine. And to do that, we've got to follow the rib around for that vertebrae, or go from the vertebrae, follow the rib around and see where we need to put a pad. So if we have this bit of curvature here and we want to straighten it up, this is the apex of the curve. Let's follow that rib around. We need to put a support here. Whereas on, say, this one around here, we follow this vertebra around and we would need to put a support against this rib here. Now, those pictures I showed a moment ago of off-the-shelf pads were vertical. And if you've got a vertical pad pushing against a rib that's already just out of position, it's going to push it over further and you're going to make the curvature worse. So it's important that the forces go up along the rib, as if you were putting your cupped hand underneath there in the direction the rib's going to straighten up the vertebrae you're working on. And there are devices in the market that do this. So here is a device where the pad is on a ball joint, so you can rotate it around to the position you put your hand in, so you can push along the rib to match the vertebra and push against the vertebrae you're trying to correct. And here's another example where you can see that the pads are not lined up for somebody who's got a scoliosis, and the pads have been rotated to accommodate the needs of pushing against the ribs in the right direction. So that's looking at an aspect of sitting and skeletal development. Let's move on to standing. Now, there are benefits of standing for all ages. They help you with your breathing. You can get your much more air into your chest if you're upright. It helps with blood circulation, bladder function, bowel function, anything that's going on inside the thorax. There's a whole lot of soft area below the diaphragm and above the pelvis where lots of things are going on. And if you're sitting down, these are all compressed. When you're standing, they're all opened up. But also, bones develop better if they've got a load on them. So standing helps to develop strength of the bones. It helps correct joint development. Contracture prevention is in there as well. See if that helps a bit. It helps develop your range of motion because of the activities that you can do when standing up. It helps to control against spasticity. Obviously, you're standing up, there isn't pressure relief underneath the pelvis. There's a psychosocial elements of standing, you're meeting people face to face. And relating to all the things on the other bullet points, it has health economics. This is a whole webinar on its own, but these are such important aspects of standing for all ages. And the research data shows just an hour a day standing has such an important impact on all these different elements. And standing is important for all ages. And not all standing can be done vertically. Some people have disabilities that they can't cope with being fully vertical, but we can get some of the benefits of getting them at least halfway there. So moving on to best practice overall, one thing that I would recommend is do keep up to date with the international, European and British standards. They are important because they've been developed to improve product safety. And if you know that a product that you're issuing meets an international or British standard, you know that it's been tested for aspects of safety. Some of the standards cover guidelines for understanding these rather more technical standards. And there's some of them are guidelines for best practice. So they affect more the clinical side of things rather than the products themselves. So first of all, let's discuss, are the products up to standard? And there is a international standard that's also been adopted in the UK. If it says BES for it, it doesn't stand for bullshit, it stands for British Standard. And if there's ISO in front of it, it means it's an international standard. And there's one, well, anything that says 16840 in the front of it is a seating standard. And part 3 in that family is one that looks at postural support devices, which could be belts and harnesses, it could be head supports, it could be back supports, it could be arm supports, it could be foot supports. And it has a series of static tests when there's a single force put on them. There's an impact test when something is like a heavy ball is thrown against the item. And then we've got repetitive load strengths, which are more important for belts and harnesses. And I'll give you an example of one of these. This is the test apparatus that you would see for testing a repetitive load on this is a pelvic positioning belt. And this black shape in the middle here is representing going across the thighs. And then there's a fixation point underneath. This belt is designed to be fixed with grommets. And the system here puts a repetitive load 1,000 times to see what happens to the belt. And if we start with this picture here, if you look where the arrow is pointing down the bottom, there are 2 little blue marks. This is at the start of the test. And then there's a load put up and down through this mechanism here 1,000 times to see whether the belt stretches or slips at all in those 1,000 repeats. And here is the result after the 1,000 tests. And the test says there can't be more than 10 millimeters movement and slippage after 1,000 repeated loads. And as you can see here, the 2 blue marks have moved apart by 2 or 3 millimeters. So that would have passed because the requirement in the pass-fail is less than 10 millimeters. Whereas this is another belt that was tested and the blue marks have moved apart from being together here, they've moved apart there. So that was a 56 millimeters of slip and that belt would have failed. And obviously having belts holding in place is important because they slip and people can slip underneath them. They're not holding people in position. So this is very much a safety element. And here's another, it's the same belt we saw earlier before. We saw it earlier before the test. At the end of the test, the webbing had started to split and before long that could have pulled away and therefore that would have failed the standard. So we talked about the product. What about your practices up to standard? A couple of years ago, we published a British standard, and that was called Selection, Placement and Fixation of Flexible Postural Support Devices and Seating. It's a specification. So very quickly, I was wondering if you could use your symbols on your Zoom system to use your thumbs up if you ever heard of the standard. I can't see the results, but Sophie, you can probably let me know if anybody has got their thumbs up.
Yeah, there's already a few people that's raised their hands. Let's see here.
Okay, I can't see that what you can all see, but how many of you, how many people, roughly is it about half or is it a third?
So far as I can see, it's 4 people that's raised their hands.
Okay. All right. Well, this is quite an important standard. It is a British standard, so everybody in this country should be following it. And I'll just haul out one example of what's in this standard to hopefully show you its use. And that's for the placement of a pelvic positioning belt. And this arose because at one stage, the MHRA had put out a guidance that suggested people should put the pelvic positioning belt at this 45-degree position, is what you'd expect to see normally with transportation in your car, an aircraft or whatever. However, there have been reports both in the UK and the United States public available to show a number of people, as a result of this position, have submarined underneath the belt in normal seating circumstances. And the reason really is that if you look at the distance of this red line here, which is the belt, when you've got a sphere of a pelvis, the greatest distance is going to be across its diameter. So if you put that there, the belt is going to be its longest position. If we move the belt forward and in front of the greater trochanter, you'll end up that distance is somewhat less than it was when it was going there. So you can't submarine underneath it. And also in that position, it shows that you can actually offload from your ITs and lean forward. So you're taking the pressure off the pelvis against the cushion, and also you end up being able to reach further forward. So if we go here, this is showing the pressure mapping. On the left is showing how much pressure there was still underneath the pelvis, bearing in mind that in this picture, the thighs are going upwards out of the picture. So this is the left thigh here, and that's the right thigh. And this is the pelvic area here. The belt at 45 degrees, there's still a lot of pressure on the back of the pelvis, where when the belt was at 60 degrees, that's in front of the greater trochanter, it was possible to completely offload off the pelvis. So apart from the practical advice in this standard for when you're handling a belt for when you've got somebody with a posterior pelvic tendency, it does give you the benefit for the individual. You have the opportunity to reduce the pressure on the ITs. It gives the person a chance to be able to off-lift the pressure on the ITs by moving forward. Gives them greater reach and functionality. And it's more secure positioning because they can't submarine underneath it. So the advice in this standard is practical, and it does cover pelvic belts. It covers anterior chest harnesses, ankle supports, wrist supports, head supports. So it's a broad rating standards. And as I say, it does cover the selection, the positioning of the belts as well, and fastening of them. And remember that when we're talking about a pelvic belt, in this circumstance, these are positioning belts and not restraints. So 45-degree position is great for restraints. They stop you from flying out the seat when you run into the vehicle in front, but they're not there for positioning you for function. So coming to the end of this, just something I found was looking at some of the pictures on the internet, and there was something I saw described as an activity seat, and this is what it was. Now, just looking what's in here, the lateral supports there really seem to impede this person's activity. The arm supports, you couldn't put your arms on. There's something stuck between the legs, which I guess is supposed to be there for positioning, because it doesn't seem to be doing much for abduction. There's an unpadded belt there, which is at 45 degrees. With all the things we're talking about, I think this seat has potential to do more harm than good, but maybe we can discuss that in the Q&A session later. So coming to the end, can we do another set of polls, please, Sophie? All right, so there are 4 questions here. If you could work your way down with the slider. The first one looks at currently, what are your restrictions on your prescription? The second one is how much choice you have, who's responsible for what's on there, and if you need something special for an individual, what are your freedoms around there? So we'll give you people a couple of minutes to fill this in. The only reason we've got this, by the way, is just make sure that we still have an audience attending. At least when you're in a normal lecture room or whatever, you can see people walking out. Here we don't have that privilege. So we put the polls in just to make sure we still have an audience and we're not talking to ourselves.
I can see that they're slowly coming in. It might just be because some of the different options is taking a little bit longer.
Yeah. Well, there are four different polls in there, in effect, and there are quite a few options in each one. And that takes a little bit of thinking.
So we're having 50% have now voted. Should we stop at around 70 again, Barend?
Yep, I think so. Because not everybody likes filling questionnaires or polls.
Okay, we're at 68, so I think I'll end it for now. I can see that there's not. Oh, we are at 70. I'll end the poll then.
And if we could share the results.
Yes.
So people's prescription options are restricted most by price. Next one is by a limited choice because of a standard equipment list. Only 15% have no restrictions at all, which is an interesting balance in there. When we send out the webinar, Sophie, do we send out the result of the polls as well so people can see this in a bit more detail?
We can do, definitely, yeah.
So most people would like a wider choice of equipment. And where the prescribing restrictions apply, their immediate manager would be the person, but there are people that need to be approached overall. And if you believe a particular piece of equipment is necessary for a client, are you able to request it? So 3/4 overall would probably be able to get that. So that is a point, because this is really coming up to where we are on knowing your power. So where do your powers lie is the quick question here. Is it within your contract of employment? Are you restricted by your contract that says you can't go beyond what is on the prescription list? Or is it within your professional affiliations? By signing up to being a member of the BAOT or the equivalent for physios or engineers, are you, do you have the power within your professional affiliations or within your contract to demand what you consider to be the best for your patient? And going back to doctors and surgeons, I know of many cases in surgery where a consultant surgeon does not like the equipment that's been passed to him, maybe because it's a little bit dirty or because it's not what he had asked for. And they've been known just to snap in a piece of, expensive piece of equipment in half and throw it in the bin and say, this is not what I've prescribed. Have you got that kind of right as a therapist or engineer to do this with the equipment that you're being asked to provide when you don't think it's the best? And that's maybe a slightly aggressive, antagonistic question, but maybe we should be asking these questions of ourselves. Have we got the power to the best for our patient we think we can do? And part of the problem we have around the country, we see this in Scotland, we see this in England, is that a lot of procurement going on is trying to commoditize whatever they're doing. It's easier for them to tick some boxes. But most of what we're talking about here is prescription products They are prescribed for an individual patient's needs, and they are not commodities. So basically, we're suggesting that part of this is know your power, is find out if you can ensure that you do have a choice and ensure that your patient has a choice. And these days, much more than 20 years ago, the patients, the clients are involved in the decision. And then when they get involved, they're more likely to make use of the equipment. So that is all part of the important part of the whole equation. So to finish off with, BES Healthcare is there to help you if required. We have programs for training of staff. We can help with training of carers and clients. We can give equipment advice, not just of the equipment that we use, but any other equipment around the place. We're going to give advice on standards, and we can give advice on best practice. So at this stage, I'm going to pass over to Charlotte, who's going to introduce you to MOVE's activities.
Brilliant.
And Charlotte, you have the screen.
Thank you very much. Yes, let me just share my screen. A seamless transition. Brill. Okay, so yes, so hi everyone, I'm Charlotte and I'm the director at MOVE Europe. I have been working with MOVE for over 4 years now, and I've been leading the organisation for the last 3. So I will talk to you in a little bit more detail about who we are in a second. But what I'm going to whiz through today are these 4 areas. So I'm going to talk very quickly about the principles of the MOVE programme and our underlying foundations. We're going to discuss very briefly about how MOVE interacts and works with postural management aims and other frameworks, and discuss the MOVE programme's 6 steps in practice. So it's a 6-step programme. How do these 6 steps work to achieve functional outcomes? I'll briefly talk about the outcomes and benefits of MOVE, and I've got a little video to show you which puts it all into perspective for you. And then finally, we'll talk about MOVE in a post-COVID-19 world. So thinking about the current situation that we are in at the moment, how can MOVE help to address some of the challenges that we are facing? So before I kick off on that, let's talk about who we are and where we work. So MOVE is an international programme. We work across the whole of the world. We have 2 organisations that run MOVE. There's MOVE International that look after the MOVE programme in the US and other countries around there. And then we have MOVE Europe, which is us. And we run the programme predominantly in the UK, but we also have hubs of activity in Austria, in Germany, Denmark, and we work quite a lot in Russia as well. So MOVE began in the early 1980s. It was started in California and spread very quickly across the US because of its success, and then came to the UK in the 1990s, which is when our organisation was set up. Now, looking at our work in a bit more detail, we currently work with 145 schools across the UK that you can see on the map there. And we work alongside these schools with numerous physiotherapy and occupational therapy teams as well. And MOVE, as well as being used in schools, is also used in some adult services as well. And while I talk about the principles of MOVE being relating to children today, the principles very much relate to adults or children of any age. We currently have just over 1,100 children on the programme, and we've got thousands more benefiting from the MOVE ethos, which I will discuss in a little bit more detail later on. So with all of this, you might be thinking, well, why was MOVE set up and what's it all about? Well, MOVE was started by a special needs teacher who was working with a class of children with complex learning difficulties in her school in California. And what she was finding was that students were losing motor skills over their school journey. They were leaving school with much fewer skills than they had when they started school at 3, 4, 5. And they were becoming more passive, developing more contractures, and she described it as becoming more chair-shaped. And she wanted to understand whether there's anything she could do and her team could do to try and combat some of this harm that was taking place. And she found that the majority of her staff's team, when she looked at it in more detail, was spent on these 4 areas. So lots of complex medical needs of the students that she was working with, meaning that was taking up a long time in their day. They were also passively moving students between activities and between rooms, and children were mostly being moved in their wheelchairs. Meal times were taking up a lot of time, and then personal care was taking up the remainder of that team's day, which meant that there was a very limited time left within that education day for any structured teaching or therapy input. So the teacher obviously found that this was, unacceptable, and started to think about, okay, we have to do all of these tasks within a day anyway. How can we make these more functional and more purposeful for the children? And this is where MOVE was formed. And the reason you'll see MOVE in capitals is because it's an acronym. So it stands for Movement Opportunities via Education and via Experiences as well. So MOVE was developed not to be an add-on, an additional session to that child's day, but what it actually talked about was about threading movement opportunities throughout the daily routines that are already taking place. And it's also useful to reflect on physio before MOVE as well. So this is a testimonial from a physiotherapist who has since been using the MOVE programme for a number of years. And while I'm not saying that this is the case for every physio or all physio provision, I think it also highlights the need to incorporate movement opportunities throughout the child's day. I think particularly you can bring out here the fact that the physio is taking students out of classrooms to work on physio skills in a separate session, returning them to their classrooms and not having any real understanding or oversight about whether those movement skills were being embedded into their routines or whether they were just something that was happening once a week with her. And she found that in best case scenarios, students were maintaining skills, but in many cases, students were actually deteriorating over time. And so this is where the principles of MOVE come into play. So the clues in the title, MOVE believes in opportunities. It's in the acronym there. So we talk about providing as many opportunities as we can throughout the child's daily routine to practice skills. But those skills aren't just done for practicing sake. They have to be functional skills that serve a purpose for the individual at the centre of the programme. And they have to be motivating for that child. So we have to work on skills and activities that are enjoyable, that are motivating, and we also have to work towards goals that are motivating for the child and the family, which I'll come on to in a little bit more detail in a second. And because we believe that we have to provide these opportunities throughout the child's day and throughout their whole day, it naturally follows that we have to develop the whole team around the individual to feel confident, to have the knowledge and the ability to practice motor skills effectively and confidently. It can't just be the responsibility of you guys as therapists to take on this responsibility. We have to find a way that everybody can work on this. And this is where MOVE is really beneficial, because MOVE is a framework that brings together good practice that already happens in education and therapy, and brings it all together under the same umbrella to put it into a framework that everybody can understand, from education, from family, and from therapy as well, to ensure that movement skills are embedded all day, every day. And this is one of our OTs. So this is an OT that runs MOVE across, I think it's around 20 mainstream settings in Greenwich, in Oxley's NHS Foundation Trust. And again, highlights the benefits of MOVE in action. So particularly talking around the fact that the programmes are easy to follow and child-centred. So even if you're not working in specialist settings, MOVE can be followed by anybody without, it can be followed by families, by nursery staff, by teaching assistants. And the second benefit that this occupational therapist highlighted is that it has enabled students to remain integrated with their peers and settings. So really drives home, particularly on the topic of inclusion, the importance of enabling that child to remain integrated in their daily routines. And it very much aligns with what Barend was saying earlier around all the different ways that harm can manifest itself. Actually here within MOVE, you've got the flip side of that, of all of the different benefits of using this approach, and that has massive add-on benefits for their education, family benefits and social benefits, which I'll talk about more in a second. So before I go on to the 6 steps of MOVE in practice, I think it's just useful to very quickly reflect on the interplay, I suppose, between postural management and the MOVE programme. Because sometimes when therapists come to MOVE or hear about MOVE, there is a view that the aims of postural management and MOVE are quite separate and are competing, but actually they are 2 sides of the same coin. And when used together as part of that whole 24-hour management process, it can lead to really effective outcomes. And on the left-hand side of your screen, you've got the kind of key aims of postural management, or the key definition of postural management. And these very much tie in with the aims and outcomes of the MOVE programme. We are both working towards enhancing functional performance, so MOVE teaches functional skills at all times. And the outcome of both is preventing harm. We are both aiming to prevent harm to body systems, and MOVE achieves this by teaching students more functional skills. They can gain more independent movement, and there's less of a need to rely on specialist equipment, on specialist intervention, and on medical procedures down the line as well. And this is a way of talking about this that one of our MOVE trainers, our physios, talks about. I think she's in the webinar today. And it's always really stuck with me as a useful way of thinking about this process. And we're all aiming to prevent long-term harm, contractures, deformities for the individuals that we are working with. And it's a very similar process to holding back the tide. We're putting these systems in place to prevent that long-term damage. And if we're going to look at this in the photo of the left in isolated action, we might just put in 1, 2, or 3 key things within that child's week to aim to prevent that contracture or deformity taking place. We're not going to be particularly effective in delivering that if we're just one part of that team working on it. But what we actually need to get to a point is the photo on the right-hand side, which is when I ended up going down a rabbit hole about this whole flood management system when I was preparing for this webinar. But we need to have a coordinated plan. And this is a Dutch seawall, and went from my research, took 500 architects, civil engineers, contractors, equipment providers. All of these people from different teams work together in a coordinated plan with the same goal of preventing long-term damage to that country. And we need to apply exactly the same principles when we're working with individuals with complex physical needs. And in my research on this seawall, I came across this quote that said, "The Netherlands isn't a fact, it's a choice of its people." And again, exactly the same applies to us. We have to make a choice to work together on this and to have a framework in place that allows all of these different teams to come together to form an effective multidisciplinary team and to work towards the same goal of preventing harm. And I think I'm not going to say anything new to anybody here. I think Barend highlighted it perfectly earlier as well. To prevent harm, there is so much benefit in starting early. We have to start as early as possible. The research has been consistent on this for such a long time now. And I think it's just useful to reflect on that. And we use MOVE with children from kind of 18 months upwards, some even younger, because we just consistently see the benefits of maximising on those times in your early development when your neural pathways are still very malleable. And this quote from a piece of research just highlights exactly that in a much more succinct form than I can. And it really supports the MOVE programme principles. Children learn best in supported natural settings where training is personalised to their enjoyment. So again, ties in with the MOVE principle of motivation, of activities that they enjoy and they want to be a part of. It also then talks about task-specific motor training interventions are recommended as the new paradigm of care. And that's what MOVE talks about again. We're always looking at not just practicing a skill for a skill's sake, but actually what's the purpose of that? What activity can they achieve as a result of learning that skill? So we're very, very much focused on the functional benefits of new skills. Okay, so those are the principles. That's how it kind of interplays with other frameworks. And now what I'm going to whiz through is the 6 steps of the MOVE program. So normally we deliver training on these steps, which is a 2-day course. So I'm going to give you the headlines of all of these very quickly. The first step of MOVE is step 1, which is the assessment step. And this is very much a can-do strengths-based assessment. And it ties back into Barend's webinar earlier, talking about, you know, if a family or a child is consistently told you will never do that, they will begin to believe that. And MOVE flips that on its head and talks about, actually, look at all the skills you already have in place, and then let's build on those skills to achieve your goals. So it's a can-do assessment, a conversation with the whole team, and the assessment is focused on the skills of sitting, standing, and walking. So on the right-hand side here, you can see the 16 skill categories that the MOVE assessment looks at. And those 16 skill categories from A to P are all of the different skills involved in sitting, standing, and walking. And each of those categories is broken down into motor milestones. So the assessment looks at a total of 72 motor milestones, which are all included because they have a functional purpose. So this is an example of one of those categories. So category A looks at sitting, and it works bottom up. So we would start at A7. Can the body physically be tolerated being placed in a sitting position? Moving up to A1, can the individual sit on a flat surface such as a bed or for 30 minutes without prompts? It's a very detailed assessment and really gives you a structured framework to work towards improving skill practices. Now, once we've looked at that in step 1, we are then going to look at goal setting. And this is what I think really sets MOVE apart. So in step 2 and in the goal setting process, it is the individual and the family that set those goals that are most important to them. It's not the professional's job to set the goals for the child. We actually, we say that the individuals and their families are the ones that can choose the goals that will make a biggest difference to their quality of life in the long term. And because of this, everyone is more motivated to work on those goals because they have of long-term importance. And every MOVE goal is always included in this format. So to be able to achieve something so that they can. So to give you an example, a goal we have a lot is to be able to stand for 2 minutes holding onto a bar so that they can be changed more easily when out and about in town and not have to be laid down on the disabled toilet floor. So really functional goals that make a big difference to quality of life. Once we've set these long-term goals, we then break them down into smaller manageable chunks in task analysis. So we coordinate everybody's efforts on 1 or 2 key critical skills. And then in steps 4 and 5, we look at the amount of physical support that child needs now and how we can reduce that over time. So in step 4, we would look at how the child works on that activity now. So for example, if their goal is to sit on a normal chair to eat dinner with their family in a restaurant. Step 4, we look at how are they currently eating their dinner? What support do they have in place? Is that a headrest? Is it a chest support? And we put a plan, we measure that support. And then in step 5, we put a plan in place to reduce that support over time. So I'm not going to go into these in any detail now, but in MOVE, we have 2 different prompt adjustment plans. So we have a sitting prompt adjustment plan, which is the one on the right. And then we have a standing and walking prompt adjustment plan, which is the one on the left. So it's a very detailed way of assessing how much support the child needs now and enabling the whole team to understand the purpose of that support and whether there are any times in the day where we could potentially reduce or lower that support for a period of time, to encourage that more active functional participation. And then once we've done all of that, we've done the planning, we've set the goals, we've looked at the support. Teaching the skills is the step where we really then embed it into their daily routine. And that's where, you know, that multidisciplinary focus is so, so important, because the education teams are the ones that are there day in, day out, and then they will be working on how they can include that into the child's education targets and into their routines and activities. So those are the 6 steps of Move, and I'm sure you can start to understand some of the benefits of the Move programme. And Barend talked about this in much more detail than I will now, because I think he summed it up perfectly. But you can see the health benefits just from being upright in more opportunities. Active weight bearing leads to, improved bone density, better digestion, circulation. But there's also add-on benefits in confidence, in self-esteem. We always hear stories and case studies of communication skyrocketing after an individual has learned or independent movement. And the benefits aren't just for the child. There's also huge family benefits as well. So we're really preventing harm for the children, but also for a number of other members of that family, of the team as well. So I could talk about this all day long, but what I'm going to do is just share this video with you. Hopefully you can hear it. It's just music. So I think that just brings it all to life. And the key with that is that's the education team all day, every day, putting those movement opportunities into that child's daily routine. And I just think, yeah, it just sums it up perfectly, the importance of thinking about the whole picture and trying to incorporate that whole team. And interestingly, that was Ibby before COVID, and Ibby was off of his feet. He was at home for the whole time. He's quite complex medical needs, and he lost the ability to walk and weight bear during COVID. And so he came back to school back in a wheelchair, and they were unsure actually if he was going to be able to stand again because of the implications of that. And I just think that in itself summarizes the reason why MOVE is so important now more than ever before. You know, I think I've got a poll, haven't I, Sophie? I don't know if I've got time, I can leave it if not. But I think there we go, thank you.
Yeah, no worries.
So it's just interesting for you guys as therapists to think about your workload, and I'd be really interested to see how your workload is currently, because the story that I'm hearing across the country is that therapy teams are feeling more stretched than they ever have been, struggling to assess as many children as they need to, and struggling with massive caseloads. Is that the case for you guys? Let's have a look, see the response.
I think we're up to 60% people have voted.
That's fine, yeah. Let's have a look and see if we can get a bit of Yeah, so 77% of you have got a higher workload than pre-COVID, and 44% of you, higher than before. That reflects the conversations that I've been having over the last 6 months or so. And so MOVE is a way of really maximising on the opportunities to include that wider team in skills practice, where you are being more stretched than ever before. It's more vital than ever before to get the people that see the child every day to have the same focus on movement skills that you have as therapists. And so, we saw that, in that case study with Ibby, he'd regressed massively, he'd lost huge skills, and that had a massive impact on his quality of life. But the good news is that because MOVE was so well embedded in the school, as soon as he came straight back in January, they were straight back on it, practicing those movement skills all day, every day, and he is back on his feet. And I actually got sent a video yesterday of him cartwheeling around the playground. So for a time we thought he wasn't going to regain those skills, and because MOVE has been so well embedded and the education team have run with it so well, he's got those skills back and learnt more, which is fantastic. These stats just highlight that. MOVE has been supported with family involvement. It's upskilled the teaching staff to be more involved with mobility progression, and it really is more vital now than it feels like it ever has been before. So thank you very much. Those are my contact details, which I'm sure will be sent out anyway post-webinar should you have any further comments or questions that you want to ask. Sophie, I'll hand back to you.
Thank you, Charlotte. Thank you for your presentation. If you could just, I'm not sure if I have, there we are.
Yeah.
Everyone's back. Thank you again, Barend and Charlotte, for your presentation. I think we're going to be 5 minutes over time. So for those who might need to leave, that's absolutely okay. For those who can stay, that's great. I will now pause the recording.